Party. Everybody, welcome. All right. So, uh, what I had done I had sent basically went through the Cowan chapter of respiratory, and so I'm not going to do I'm going to go back and do this as the Nestor chapter, chapter 21, because there's some interesting stuff I thought that I would throw in with regard to. They don't cover diphtheria whatsoever, so I thought that worth a mention, even though it's not something you normally would contact. A couple of little things. I scroll through it, and then we'll get ready to start skin. And so then, in the 2 weeks we have left, commencing Monday, so we have to get through skin, urinary tract. Skin probably takes about 2 days, less than you think. Urinary tract probably takes about 3 days, and I'll have to find a way to get in what I can about wounds and any other selective topics in there, which means I'll probably have to send at least one or two, depending on how frisky I'm feeling. So moving on. So this is the interesting thing is the tie-in, and even though Cowan always does pink eye in skin, or basically they're dealing with it as a surface, I think there's an overlap with respiratory. The interesting part of why there's such an overlap is the causative agents, and they're pretty consistently, in addition to some of the ones that they commented on in some of the perhaps more recently identified agents, are these two: Haemophilus influenza, which is normal flora in your throat, as is Streptococcus pneumonia in a great many of us. Is that, and typically the encapsulated one is more of the pathogenic one that's there. They adhere very well, uh, and that's really, as I said before, the underlying theme why amoxicillin is used so consistently, assuming there's not an allergy to penicillin that's there. So it's been proven over time. The interesting part is this, that I thought biofilms, now that we begin to understand them more, and this is really what, and it's a good illustration, they don't have any other text, even though they're both McGraw-Hill texts, is the ventilation tube. You can see the little, that's the cannula. A cannula, when you see something that's cannulated, it has got a canal in it, a little opening that allows material, in this case fluid, to go out, and you can see the enlarged cap that goes, that basically when you insert it from the outside, that way it doesn't go inside, so to speak. And what happens as it heals through this very tiny stab incision, they're very, very tiny, this little rubberized object will come out over time as it heals, as it basically does its job. And so a lot of times you don't notice it. There might be little bits of drainage that come out of a baby or a child's ear. They may come out when they're bathing, that type of thing. Every so often, a parent will see a little, and they'll kind of feel, what's this stuff? And they'll feel a little, and it's probably the tube. You know what the parents do with it then? Under the pillow. Tube fairy. What fun are you? Your mom and dad didn't do the tooth fairy thing? Oh, I'm getting old. Poker's gone up. When I was kids, we were lucky to get a quarter, a nickel or a dime. My kids folding money. That's yeah. My oldest probably now would want stock options. I'm waiting for his kids to start to lose their teeth. That's got to be coming pretty soon. She's going to be 6, so we got to have some teeth working on that thing. My younger granddaughter. All right, moving on. I'm going to have to drop the tube fairy joke. Okay. I have another one of those, but we don't get to it until wounds. Brace yourselves. I don't like any of you. And I see your cadre of 2 decided to blow it off again this morning. All right, moving on. So much for that. So we did strep throat at length. Don't have to go through all that stuff. Blah blah blah. A lot of stuff that's on that. The rheumatic fever is really significant, and we understand that's why the importance, because of all these what they call streptococcal sequelae, these immunological complications. So all of those are part of it. They're autoimmune in nature. You can see even when this book was published, which is within the last 5 years, it's still 3% of severe untreated cases, 10 to 20 million cases of rheumatic fever, which causes significant damage to heart valves, as well as joint deformities. This is the one we're going to cover more in skin, this acute post-streptococcal glomerulonephritis. And what happens is these clumps of antigen and antibody and complement land within the glomeruli, and effectively that clogs the system. And again, the kidney has one response. Did you start doing kidney and A and P? Yeah, the kidney has one response to damage. It shuts down. Doesn't matter what it is, it will shut down. And so what happens, because of this, it requires, if you can address the problem, push fluids, get the kidney working again, antibiotics, whatever the methods that are employed currently for this, and I can't elucidate to them, but it can and it happens with regard to strep. It happens more commonly with impetigo, and we'll get to that in skin. Impetigo is a very, very common skin condition. The streptococcal part is much more notorious for this. But as I said in the dictation, my stepson, when he was in high school, ended up with acute glomerulonephritis from strep throat. That effectively went untreated because he really didn't make a big deal. It was a sore throat, it went away, etc. This is the one they don't mention because we're immunized. Okay, it's very, very interesting, and it's brilliant because of the anecdote that when I first started to teach micro, which is more than 20 years ago, at Chatham, we had a young lady who was older than some of the other students. So I'm going to tell you, she was probably around 30, and she already had a medical degree. She was from Russia, and she'd married a GI, and not an unusual story. And they had a kid, and they immigrated to this country. And her doctoral, she was trained in psychiatry. Okay, her doctoral degree wouldn't transfer, and so it would cost some money to get the necessary courses and take the necessary examinations to get her MD license in this country. But she had trained in Siberia in and around this time. Okay, where she saw this outbreak of diphtheria when she was probably a medical student at that time. That was there. Unbelievable. We were about 55 in this lecture hall that I was doing. And she started to tell about what was going on. Diphtheria creates a toxin. It's a classic toxin called an AB toxin. And what happens is it causes damage to the lining. That's why it's upper respiratory, typically in the throat, and it peels off. And the toxin does other nefarious stuff. And so they can't breathe because it's clogging up. It's like a pseudo membrane, a false membrane that forms. And they're riding on it in pain, heart abnormalities, kidney abnormalities. And she's describing people literally falling down, writhing in pain, and dying in front of her. I mean, we all sat there, mouths steadily widening from her description. Okay, so she was in the middle of this thing. And so the pseudomembrane, heart failure, kidney failure, paralysis, horrible disease. So it's one of the, along with tetanus and pertussis, whooping cough, which is in this, and they didn't really have that in that PowerPoint. So it's a couple of things I wanted to share with you because I think they're important. So this is the name of it, and we call everything diphtheroids. They're mostly normal flora. They're very easily identifiable microscopically with a simple stain of methylene blue because they form what are called metachromatic granules. They're very, very interesting to look at. And they form these palisades. They sort of divide but stay partially attached, but random planes. So you get these interesting sort of a pattern that's fairly distinctive when you see it. That's what I wanted to share that with you. And there's the AB toxin. Human to human, easily spread, can come from fomites, etc. Even with treatment, the unimmunized 10% mortality. That's really significant. So now when we talk about DTaP, which is when you get a tetanus shot, you get all three: diphtheria, tetanus, and what's called acellular pertussis. When we get to pertussis, that's always been the hard one to get the antitoxin and the immunization at work, because there's a lot of times where it just didn't seem to work as efficiently. The tetanus worked very consistently in diphtheria. So even for a while back in the 90s, they just did DT injections because they couldn't work with it. That's why every so often you'll see a case of pertussis that lingers in somebody who has, particularly in an adult, or an older child where they'll have a chronic cough and eventually they'll culture it out. And it'll be one of these, it's not life threatening, it's just unpleasant and it's uncomfortable and it's noisy. But other than that, it's just one of those things that requires long term antibiotic treatment. And this is all the viral, the common cold, not a big deal with regard to that. What's interesting, and it's typically rhino or picoRNA viruses, the most common are that rhinovirus, hand washing, hand washing, hand washing, etc. You can scroll through that as easily as I can. The adenovirus, the other PowerPoint didn't talk about. Traditionally, the cold and the typical mild to moderate upper respiratory infections were rhinoviruses, adenoviruses, interestingly, sort of nondescript coronaviruses. So now when you say coronavirus, people, oh my God, oh my God, get away from me. The reality is that these were unusual or novel coronaviruses, the SARS-CoV-1, COVID-19, which is SARS-CoV-2, and MERS, and but they are more severe. Typically, viral upper respiratory infections are you don't get a fever, you don't get remarkably sick, you get better in 7 to 10 days. Your body's response is immunological in nature and nothing else. It really is. It's not doing a lot of damage. These are a little bit different. Okay, it's named adeno because it targets glands, and the most notorious finding is a swollen gland. That's there, and you feel for the glands, preauricular nodes in your throat and under here, areas where they were common, and it was typically accompanied by fever. So it was the bad cold, 101, 102 fever, swollen glands, sore throat that was like, oh my God, it'll never get better, that kind of things, conjunctivitis, diarrhea, severe cough and chest pain confused with pneumonia, longer recovery time. Still a viral infection, but a viral infection is there. So more than 50 different types. That's why it's very difficult to come up with immunizations, even though periodically they've had one. Sometimes you'll see, sometimes they use it in military with regard to this. Remains infectious in the environment a bit longer. It's non-enveloped, just like a naked virus, just like the common cold. More resistant to some of the disinfecting agents that we use so commonly. Okay, so again, humans, school children, inadequate chlorinated pools. So I mean, and that's a recurring theme that you're going to begin to see as we talk about disease spread. There are certain areas where it's really important if you're in a public pool, if you're at a pool at a Y, if you have your own, you invite other folks over. Hot tubs are the same way. To have to understand that you got to pay some attention to that stuff. I mean, those should be checked every day. Dipsticks are relatively cheap. Check them every day and all that stuff. I mean, we do that pretty routinely, or we did when we had an above ground pool for a long time until it finally died. And we need to use the hot tub more. Mojitos, midnight, hot tub. See, that's right, my kind of guy. I, I, sh- I shouldn't say that. That would be. I get strike that. Moving on. So all of that type of stuff is there. Yeah, avoid crowds. I always do. They did the whole pneumonia thing fairly thoroughly. Streptococcal pneumonia, number one on the hit parade, encapsulated, most common complication of lower viral infections, particularly the cause of death post influenza, post COVID, all of it, mostly pneumonia. The lung is damaged. Now you get the ability, now it's much more susceptible to bacterial infection, which is considerably more damaging. And again, particularly in the elderly, perhaps more so than anything else. Okay, leading cause of death due to infectious disease, and consistently is. Doesn't matter. That statistic has never changed. We look at the sputum because there's certain things we see blood or blood tinged sputum, and you might remember in the dictation, if you had a chance to listen to it, it has to do whether it's rust color, whether it's all red. So that when we talk about things, typically strep pneumonia, alpha hemolytic, so it begins to break down, but only partially the blood, so you get the round or rusty looking colored sputum. Tuberculosis does more damage, so you actually get frank blood. and it's sort of a mixture, like a swirl pattern, where Klebsiella pneumonia really is very, very destructive, but not hemolytic, but you end up with almost a cherry red kind of a sputum. So we look at that, and obviously you culture it. Sounds are fairly distinctive. You'll probably get schooled on that fairly well if you're in the nursing curriculum, I would think. Clogs the alveoli, pain associated with it, damage to the escalator, etc. And we classify them, as we do a lot of things these days, as community or healthcare acquired, and inevitably they are more problematic. The healthcare acquired ones, typically we see more normal microbes. Being on a ventilator is not a winning position. I mean, it's one thing to be on one because you're having an operation, okay, for X number of hours, or they're going to turn you and put you on your tummy or things like that. Then you have to intubate, typically ventilate, but it's not easy. Multi-drug resist, yes, the trouble. The healthcare ones, really problematic. Let's see, and you can scroll through this as easily as I can. So as you can see, without treatment, and we didn't have the ability of antibiotics, what people were, they would hope that they would induce them to sweat in the hopes that it would break the fever. They would try a variety of other things. They used different kinds of infusions and herbs and things like that because they didn't have those things that were necessarily available to them. And so it was really very much touch and go for any of these pneumonia causing agents. Again, either change and so it goes by pneumococcus, streptococcus pneumonia, and diplococcus pneumonia are all interchangeable. Whether it's encapsulated or not is really the feature that deals mostly, as it does with Klebsiella pneumonia, as it does with tuberculosis-based disease. All of those things are based on the capsule because the capsule makes it very difficult to phagocytize. In tuberculosis, it's not difficult. It gets phagocytized. It can't be destroyed. And we'll look at that a little bit more thoroughly here today with what goes on in TB, because TB is one of those resurgent diseases. Lots of different ones. There's pneumonia immunization. I think I had it. Pretty sure I had it. Because usually you get it when you're in your 60s or so, which I've unfortunately passed. Two people smiled, or you're just say just there, yeah. So, and that's what you see. In the old days, we had to use a lot. I'm just looking at radiographically a plain film. So this is a lung, nice and clear. You can see on either side. That when you see this, there's so much consolidation. There's so much fluid in the lung that cloudy appearance. It's a slam dunk for what it is that's there. So all of these things, because the lung being so intimately in contact with blood vessels, when those walls break down and the alveoli break down, heart valve infections, meningitis, all of those kinds of things. So there's a lot of destruction that occurs. As you can see, actually probably a little bit more these days have that encapsulated pneumonia. Penicillins are useful. Here's the Klebsiella, the one, and we typically see this mostly as with healthcare associated, because Klebsiella is a bacteria that's normally found in the gastrointestinal tract. So people who are incontinent, long-term hospitalizations, big problems that are there. You get this. It used to have a picture that was even redder than this. It's pretty disgusting. Okay. Abscess is septic shock. It's gram negative. Very old, very young, compromised hosts, alcoholics, institutionalized, resistant to, and this is a big problem. This is where those ESBLs, expanded spectrum beta lactamase producing bacteria, really haunt you. Here it is. Plasma encoded beta lactamase, carbapenemases, very, very few choices, very high fatality rate. And mycoplasma, that's the walking pneumonia, fairly straightforward, not a lot to it, just relatively minor symptoms, still classified. Takes 2 to 3 weeks. It has a long onset. So it's the kind of thing that you'll see around here from dormitories. No matter how careful you are with things like that, there's always going to be cases that are pneumonia or pneumonia-like, probably fall into this category, I would think. Pretty distinctive, that fried egg appearance when it colonizes, though I don't know. I've only seen this in pictures. I haven't seen it for real. And they just scroll through that. Pertussis. This is a bacterial infection, and it was awful until we had the immunization. And again, it's the immunization that's been less handy, and it makes the most. It's an inspiratory where it gets its name. The baby is trying to inhale, starve for breath. It attacks the mucociliary escalator. Very, very difficult for air to in. The baby releases this horrible sound. For parents, the croup sounded like that, but the croup was relatively easy to treat. All my kids had that. That's relatively common. You're going to see when we get to RSV. That's where that comes from, respiratory syncytial virus in older children or adults. But this was not. And this particular phase, scary, that was there. You had a mucus stage. Catarrhal was an old, for draining mucus. So catarrhal was an old, you have a catarrhal drainage. It means your mucus was coming out of your nose. Okay. So this stage, paroxysmal, is a great word for sudden. So paroxysms, okay, these sudden attacks, uncontrollable coughing, dry, blood vessels, tongue stands out, blah, that whoop sound, all of these things, very, very, very severe. Okay. So there was again a comparatively high death rate. It's called Bordetella pertussis. So if you have a pet, they periodically get a Bordetella immunization for kennel cough, which is really what that is. Okay? And so I'm constantly, emailing wherever when we board or have daycare for are we up to date? Blah blah blah, that kind of stuff. Some places are a little bit more stringent than others. Okay. So all of those things dies outside the host. That's a good thing. Inhaled ciliary action, bronchioles completely obstructed, areas of lung collapse. And again, look at this. Chief cause of death is pneumonia, or more commonly other secondary bacterial infections. Again, it's toxin related. It's back to those AB toxins that adhere, the attachment, the A component, the B. The B is the binding component, I beg your pardon, and the A is the active component. And so they just show you that and what it does and how it affects cyclic AMP, adenylate cyclase, and blah, 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 blah. So if you're, and you may, and if they get into the pathophysiology type of thing, that might be something that you'll be focusing on a little bit, I would suspect. In nursing, I don't know. You got to get back to me next term. Let me know. Look, I'm here. They tell me I'm going to be here. We signed a contract. They better be here. So you're allowed to contact me. Not allowed to visit. Highly contagious, milder in older children. So this is it's the long term. I had a few years ago. I mean, I had like 3 consecutive micro classes annually that I taught at a different institution where people had been diagnosed with, their members of their family with, for like a long term type of thing. And so it's interesting. Again, historically, there was some problem with this vaccination, and they did change it. And for a while, they took it out because it was ineffective. This is really interesting. We talked about this very early in the course, the resurgent nature of tuberculosis. In this country, we nearly had this eradicated with screening, TB tests, chest x-rays, treatment when necessary. And then in the age of immunosuppressants and immunological diseases and immune suppression diseases, a la HIV, recur. Major risk factor, no question about it, overcrowding. You need long-term, consistent exposure to this particular disease. There's still a lot of countries that require the immunization, though it's really typically, if you're going to travel, but it's typically only effective in children. I reminded everybody that my daughter had this when she was doing egg donation in India, where she went at least 3 different times for that type of thing. So, why don't we use it in this country? Because it renders the TB test ineffective. Because then at that point you're going to respond positively whenever you have it. So I mean, it sort of outlived the screening test that was so effective for a long time. Okay, so and we're learning more about it. A lot of people have what's called LTBI, latent tuberculosis infection, that were in predisposed communities, overcrowded. Somebody had that, somebody came, and they used to treat it fairly aggressively. I don't think quite as much today. Okay, so it isn't eliminated because it's that rare organism that actually multiplies inside of a white blood cell, inside of a macrophage. I like to call it hiding in plain sight. And so while it's doing that, multiplying and multiplying within a white blood cell, that white blood, that macrophage is still sending out signals that it's been invaded, and it gets surrounded by other white blood cells. It forms what we call a giant cell. So you get it's called a granuloma because the cells that surround it, you remember from your blood unit, we had granulocytes and agranulocytes. Am I ringing a bell here? Granuloma, because they look like granular cells. And that granuloma would firm up and harden. And so when they examined lungs of people who died, they had bumps in them. And what's a bump? That's a hard bump. We use the term in bone, tubercle. You learned all that stuff. Condyles, epicondyles, tubercles, tuberosities, trochanters. Oh, come on, you didn't forget all that stuff, did you? So, and they named it tuberculosis. See, clever. And if your immune system is depleted, and maybe this is what happened with HIV patients, all of a sudden they became active tuberculosis. So, in a person who's HIV positive, the development of tuberculosis is an AIDS defining illness. Now you've made the transition because normally an intact immune system would keep LTBI under check. That's there. The interesting thing is when it's kind of like a bacterial cancer. It has all the effects of cancer. You have night sweats, weight loss, fever, cough, but it's bacterial in nature. But what happens is when that granuloma gets large enough and weakens the lung, it breaks through, it explodes. And it kind of inside, what's happening is it accumulates a particularly oily kind of a material inside that white blood cell. And it develops a specific kind of necrosis that kind of looks like a cheesy, pasty kind of stuff called caseation necrosis. It's really yucky. Okay. But it's laden with bacteria. And once it bursts through, they get into the bloodstream. They can go everywhere like a metastatic cancer from the lung. And a lot of times we'll see typically tubercular lesions are more on the periphery. They're more in the outer areas, not centrally, where cancers frequently are much more centrally placed. They can be all over. That's not, you can't judge that. That's broad brush judging. But one of the things that kind of, somebody would see what we call a coin lesion, being a circular area, or a punched out lesion if it was close to the hilar area, to the trachea and the bronchi. You most likely would think lung cancer. Out in the periphery, you most likely think tuberculosis. And it was interesting is it's not really hemolyzing, and so when people would cough up stuff, they'd get blood that was sort of swirling and things like that. But when it finally traveled, it could go anywhere: bones, kidneys, joints, central nervous, miliary. Okay, and the name is miliary comes from the fact it was seeded, like the miller was taking seeds and grinding them into flour. You know, what are we old? Help me. You need to watch more old movies where they tell you about that. Like a Cooper made barrels. That's where their last name. Wheelwright and Wainwright made wheels or wagon wheels. Miller, because they were millers. Okay. John's son, Johnson, Lord help me. And you probably tried to do this in lab. Maybe you were successful. The acid fast because it fastens to the mycolic acid capsule. That's the defining feature. Strict aerobe, very long generation time. Uh, and very, very resistant, but killed relatively easily by pasteurization. So it's easy for disinfectants, but pasteurization takes care of it. Mycolic acids, because of that capsule, it prevents the fusion of the phagosome with the lysosome. Okay, multiplying the cytoplasm, inflammatory, so the cells come and you get this giant cell, and then as it begins to get walled off and granulates, the tubercle forms. And then I never asked the question, but the GON foci or GON complex, that strikes me as that's a perfect name for like NCLEX. So I've always found they have a fascination for names. Just saying. It's like in the old days, and we don't see much hepatitis B, the antigens they look for was called Australia antigen. So if you see that, the answer is hepatitis B. Try to remember these things. I'm helping you. Don't do that. I'm trying to help you. Caseation necrosis, foamy macrophages with lipids, important role, cavity or cavitating disease, voila. And it's an interesting picture. Cavities here, cavities over here. Here's the granular cells. Here it is getting into the bloodstream, etc. Here's the TB test. That you're so okay. 13. That's a pretty good size number from when this was published. So if you're thinking, what is that? Maybe 3% based on today. Well, we have 400 million people in the country, 450. So 13 million have LTBI. A very small percentage will activate. Respiratory, again, these are airborne bacteria, so they stay there, but you need a lot of exposure to that. All of those things are part of that. So to me, overcrowding. The various tests are there. And then what happens is, from a treatment perspective, we've now developed these two things called multi and extensively drug resistant. So multi-drug resistant, resisting some of the first line, which were rifampicin and isoniazid. Extremely first and many second lines. I'm not going to ask you about that for any of those things. But just to understand in general, when you see things like rifampicin or isoniazid, ethambutol, even in the old days, they used to use streptomycin. They were very, very specific anti-tubercular drugs, and you're always looking at long treatment, 6 months to a year, to treat active tuberculosis. And they're not innocent at all. They're strong medications that are there. This is the BCG vaccine. Live attenuated is called Mycobacterium bovis because it comes from cows. It doesn't bother us, but it's sort of like a look-alike kind of immunity. That BCG is really significant. That's what I had. We use it for immunotherapy in certain cancers because what it does, it acts like tuberculosis. It lays inside the cells and stimulates your immune system to fight things. So they basically put that inside of me in my bladder to deal with my bladder cancer. Unfortunately, I had a very profound immunological reaction, maybe after them doing that a dozen times, and they probably provoked an immune disease that I fight now. What are you going to do? The Legionnaires I told you about coming from the convention there. They thought it was a recurrence of the very, very famous Spanish flu. Not true. They couldn't find it. That was there. It looked just like an influenza is very severe. And we all do. Oh, I can't come to class today. I got the flu. I'll be back on Wednesday. I'll be back on Friday. You didn't have the flu. I mean, if you truly had influenza, you're in bed for a week. You're starting to feel a little bit better the next week, and you might be in 3 weeks be back to normal. You feel like your head's going to fall off. You can't stand up straight. You can't get out of the bathroom. You can't eat anything. Can't drink anything. You feel like a truck ran over you. In the old days, my mom and dad, that way back when, the folks who were, World War II vets, they called it the grip because it felt like we had a vice grip around you. It's the sickest I ever saw my dad until the day he died. a guy never had a cold. He spent a week in bed. And I said, "What's wrong?" "Oh, your dad's got the grip. He had the flu." I don't even remember when it was. It was probably, I think it was an outbreak in '68, something like that. I'm trying to remember. And other than that, he never went to the hospital for that. The only time he went to the hospital in 40 years was to visit a sick friend, until he died. So that kind of stuff was there. They thought it was this because they had people who had been exposed to it, because you had World War I vets who were part of this. And it was I told everybody, old hotel called the Bellevue Stratford. I don't know who owns it now. Very much like our William Penn downtown, if you've ever been there. Old, grandfathered in from all the heating and cooling. They had the crawl spaces dry, dusty, wet from dripping pipes. Voila. And you got this. And it turns out it's in a susceptible population, it's a high fatality rate. Tragically, we see it associated with problems with water supply. And the worst outbreak they've had since then was unfortunately here also at the Vets Hospital, Pittsburgh. I don't want to get into it, how poorly we treat our veterans. I'm just going to say that. Legionella, they named it for that. Fatal, 15% of hospitalized cases. It's not by definition contagious, and that was something that they did not understand. Aerosols from central air conditioning, nebulizers, sprays, refreshing showers, and this was more like we were seeing at the VA, water faucets, things along those lines that were there, etc. Not a whole lot to say about that. Inhalation anthrax is relatively rare. They used to be, certainly still a bioterrorism agent, which they tried to work with immediately post 9/11. Domestically, someone who worked in a laboratory milled, and when they say milling, it's chemically in the laboratory reducing the capsule so it could get through the nose hairs. That's what weaponized it. 1,000 years ago, I think either Tom Clancy or Robin, his last name escapes me, we were writing techno thrillers about that stuff being happened because they researched and they knew the Russians were doing it in a lab back in the Cold War days. And what happened, a number of people got sick and died from this. But it's very rare because most of the time it came from sheep, mostly from wool sorters disease, mostly was on their hands, cutaneous anthrax. But when they did it a lot and they didn't wear any protective equipment back in the day, they would inhale that and you get inhaled anthrax because it's typically in the wool. Now, there's obviously a lot of precautions in those industries, assuming that they're observed, etc. Gram-positive, non-modal, rod-shaped endospore forming. We play with B-sub in the lab. Everybody does. It's different factors that are there. It does respond to vibromycin and ciprofloxacin. Preventative treatment used. And if you're in the industry, I'm sure appropriate precautions. The flu. This is an important part to review. We categorize influenza viruses are unique and similar to COVID in the sense that they have the remarkable ability because they occupy other species. They're not only in humans. So when you hear swine flu, bird flu, they're not the only species. Horses can get it. Obviously, we can get it. Bats can get it. There's a lot of species, mammalian species, that can get influenza. And when they share viruses from different hosts, so what swine flu is usually a combination of human flu and bird flu in a swine who gets it on a farm. And what happens is they interchange genetic material, or whether it happens in the lab in Wuhan or in that open market in Wuhan, effectively what happens, you get multiple species and you create what's called a novel virus. Novel just means new, something was not anticipated. And that's called antigenic shift. Antigenic drift is different. Antigenic drift are subtle changes that occur in the spike proteins that allow it, just because it's genetically, it's an RNA virus and it's somewhat genetically unstable. In influenza, there's 7 to 8 identical RNA pieces that make up the genome, and they can flip flop positions and they can alter the spikes. That's called antigenic drift. That's why we typically, if you're going to get a flu shot, you have to make a different one every year because it's always changing. It's just like the whole COVID thing. How many different variants? We're going to have, it's going to be with us forever. People need to, every so often we're going to get a nasty one. And yeah, obviously there's going to be all sorts of stuff that's going to go on with regard to it. I don't even want to go there. So serious annual epidemics, it infects a lot of people. Sometimes you get it mildly, sometimes you get it severely. There's A, B, and C. We really talk about A as the one that's most severe. Okay, it's not. You might have gastrointestinal symptoms, but they're immunological. Stomach flu are enteric viruses in the picoRNA that most of us get periodically in any event. Headache, muscle aches, fever, dry cough, incubation for 2 days, acute 1 week, lingering cough, fatigue, weakness, additional days and week. Typically, you're looking at 2 to 3 weeks to get better. That's why you shouldn't throw the term around loosely. We all do. Okay, orthomyxoviruses, it's about the spikes. Hemagglutinins and neuraminidase, so we call them HA and NA. And we have all these subtypes. We know about 18 HAs, 11 NAs. Okay, more than these affect humans. They don't include H5N1, which a lot of authors think was responsible for the Spanish flu, which is an avian-based flu epidemic. This one was an H1N1. Now, typically that's included in most immunizations, some H1N1 based vaccine that was there. My middle one had that in 2009. I mean, it knocked him out for the better part of a week or two. I mean, I literally had to, he was out of Monroeville living, take him back to his apartment. I had to carry him out of the hospital. By the time they gave me the Tamiflu, it was probably past the time it was useful. So this is what happens at flip flops, and they'll show you this, that are there. And again, it's mostly just like COVID. It's immunological in nature, the way we respond to it. Secondary respiratory infections are a big player in this. Relatively small fatality, but because of the vast number of cases, the total number of fatalities are quite high. So statistics can be misleading. Secondary bacterial pneumonia. We always have epidemics. Periodically, we have pandemics. So drift are the minor mutations, the seasonal changes that we try to predict epidemiologically, versus this current infections are a mixture of those segments. And this is where we see these novel viruses. Human strain can gain novel HAs or NAs, which humans have no immunity typically to. We've not been exposed to them. So they show it to you. So here, this is the subtle changes in the spike. Here, you know, don't sleep with birds or ducks or pigs. It's life on the farm. And basically that's the way they, if you remember the movie Contagion, which is an okay movie, but fairly accurate epidemiologically, they traced it back to the source, which was a farm. And then it got into the food supply, and I don't know, blah, 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 and people started to inhale it, et cetera, et cetera. So H5N1, 1997. Okay. And so H7N9, China, 2013. So it's not, and the difficult thing, the antivirals are Tamiflu and Relenza, which are neuraminidase inhibitors, which prevent its spread. They don't allow it to escape. And so, and again, Reye syndrome, a big problem. They're saying 5 to 15. I learned 18. You're not supposed to give aspirin. Aspirin is a wonderful agent to control fever, contraindicated in children, with the exception of something called juvenile rheumatoid arthritis, which is relatively uncommon, and fever that's immediately life-threatening. Then you might alternate that with ibuprofen and Tylenol. For most of you, ibuprofen and Tylenol are the way to go. That are there, blah, 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 blah. RSV, again, the croup is really the problem in infants, and it has a lot to do with the surfactant. particularly in preemies. It's called respiratory disease of the newborn. Okay. Again, the croup is a different kind of a cough that's distinctive but equally scary to whooping cough. And and RSV has become the third of this trio of nasty viruses: influenza, whatever the strain that's going around, COVID-19, whatever variant we have now, and RSV. That's what put my mother-in-law in the hospital and really did a number on her. I agree, she's 96, and if she gets something like that again, one, I don't think she'd survive. Two, I don't think she'd be able to come home again. I mean, as it is, my wife is there for somebody else constantly. So RSV, these are paramyxa. The other ones we're going to get to, measles and mumps. There's another one called parainfluenza, which is a more mild influenza-like presentation that are there. We're starting to get some. There's really not a vaccine. They use immunoglobulins. They're actually starting to find some antivirals that work with it. Hanta, just about done. Relatively, we typically only see it in desert areas unless somebody's raising rodents for scientific purposes, or really horrible. This is the rat control thing associated with exposure to mice, particularly urine and feces, and it's airborne like tuberculosis. So dry areas are like that. Korean War, very nasty. Back historically, they called it the sweating sickness because it onset very fast, high fatality rate, tremendous sweating. Back in Henry VIII times, Renaissance, medieval times, if you will. And that's we remember the story about the Pied Piper of Hamelin trying to get rid of the rat. I mean, the whole idea, they realized eventually that the rats were the source of some of these things. But when it was discovered in Africa, where it got its name, shock and death occur in more than 30% of the cases. Not good. You live in the desert Southwest, you're aware of it. And SARS and MERS, because this is pre-COVID, when this basically was published, or just at the earliest onset of COVID. So SARS and MERS, these were the first of the novel coronaviruses, and you can see they were pretty severe. That were there, enveloped. You can see all the types of things. Pneumonia, that's part of it. Strong, and it's immunological response and cytokine storm. We know that are there. Zoonotic, likely, and again, bats, and we have some people who are super spreaders, healthcare settings, and that was MERS, and we named it because a lot of the troops coming back from our desert-based wars in relatively recent history had this, that were there. Should be about it. Yeah, there's a couple of fungal ones. The fungal ones, valley fever, again, desert Southwest, because of dry, and periodically you get the right conditions for these airborne fungi. If you look at our history, there was a Native American nation, politically correct, called the Anasazi, who magically disappeared and had a very advanced society back around 1,000 years ago. They think it was this. Okay. And so you can read about that. It's interesting. It's dust, soil, very severe. Pets can get it. My brother-in-law lives in Tucson. He's had a dog that's had it. They've had to treat. So that's coccidioides immitis capsule. Certain antifungals, and we have some, fatal without treatment. And the other one is histoplasmosis. Again, another one, typically with caving and moisture and bats play a role. And I think that's everything. All right. Goodbye. PCP I'll talk about when we talk more about AIDS. Hope you all liked all that.